Hi, everyone. Welcome to Sonata Insights Live. I am Tara Murphy, Senior Director of Global Marketing and Advocacy at Gynesonics. Sonata Insights Live is a new program that we've launched here at Gynesonics to spark conversation about fibroids, the symptoms of fibroids, and the treatment options that women can receive for their fibroids, including the Sonata Treatment, which is our product. During these episodes, you will hear from guest physicians, patients, and advocates as they share their stories and educate our audience. I am very excited for our first episode to have Dr. Erica Stockwell here with us today. Welcome, Dr. Stockwell.
Thank you. Thanks for having me. I'm excited to be here.
Wonderful to have you. I'm going to tell the audience a little bit about who you are before we get started, and then we could talk a little bit more about fibroids. Dr. Stockwell is an advanced gynecologic surgeon in Celebration, Florida. She earned her degree in biomedical engineering and physiology from the University of Minnesota, where, among other endeavors, she conducted research in microparticle technology for use as a drug delivery system. She then earned her medical degree from Midwestern University in Chicago, where she was awarded the prestigious Departmental Award in Obstetrics and Gynecology. She went on to complete a residency in obstetrics and gynecology at the University of Minnesota, where she received several accolades for surgical skills, developed robotics training curriculum for the residents, and serves as chief administrative resident. Following completion of her residency training, she pursued a fellowship in minimally invasive gynecologic surgery through the AAGL MIGS Fellowship Program in Las Vegas. She also concurrently received her MBA through the University of Nevada in Las Vegas Lee Business School. She completed both in 2017 and stayed on as faculty for the fellowship program and eventual assistant program director. She also served as director of simulation for the Sunrise HCA OBGYN residency program, assistant clinical professor for the University of Nevada, Las Vegas Medical School and OBGYN residency program, and assistant clinical professor for Touro University Medical School. In 2020, Dr. Stockwell was recruited to Celebration, Florida, where she operates as a high-volume gynecologic surgeon. She also continues to work closely with the medical device industry as a consultant and proctor, and even holds a few patents of her own. Goodness, you are a busy lady. Wow, that's impressive, very impressive. So we are so happy to have you here today. We're going to talk about fibroids. So I'd just love to have you educate our audience a little bit from the basics, just start from the very beginning and talk to them a little bit about what actually are uterine fibroids.
Yeah, well, I mean, I think, fibroids is definitely a topic that's very near and dear to my heart, something I'm very passionate about. It's definitely one of the main, things that I see and treat in my practice. And one of the main reasons why women eventually potentially need to undergo surgery. And so I think it's definitely important to educate and to gather information and also to come up with new techniques and ways to treat fibroids. And we know that fibroids are quite common. In fact, between a third to a half of women, depending on ethnicity, do have fibroids. A lot of women don't even know that they have fibroids until they have any symptoms or have potentially imaging for something else, and then they incidentally find that they have fibroids. But the way that I like to describe what fibroids are, it's basically balls of muscle tissue. So the uterus is a muscle, and the muscle lines up kind of like a brick wall, a brick layer. Fibroids are when that brick layer is disrupted. Something causes the muscles to start to swirl and create these balls of muscle tissue. So they are tumors because they're abnormal growths, but they're benign tumors. Fibroids are not cancer. They're not precancer. But they can wreak havoc. It could cause lots of issues like bleeding and pain, and sometimes issues with fertility, which I'm sure we're going to get into here.
So a lot of women have fibroids.
Mm-hmm.
how do they know if they have a fibroid?
Well, the most common symptoms of fibroids are abnormal uterine bleeding, symptom number one. Pelvic pain is also a common symptom as well, and it could be pain with their periods. It could also be pain, chronic pain, pressure, discomfort, even maybe outside of their period, pain with intercourse. Fibroids that grow large sometimes can cause a lot of bulk symptoms, can push on the bladder, can sometimes push on the bowel, make it hard to have a bowel movement, or cause urinary frequency, or cause the women to feel like they're constantly bloated, or they have a lot of pressure in their abdomen. And rarely fibroids can become so large that they can even impinge on major organs like your ureters and cause urine to back up into the kidneys, or cause edema, cause swelling in the legs because it's pushing on your lymphatics. So there could be a whole range of different symptoms that it may cause. And keep in mind, a lot of women who do have fibroids are actually asymptomatic. They don't have symptoms, and they might find that they have fibroids incidentally on imaging that they're having as part of workup for something else or another symptom that they're having.
I want to touch a little bit on the first symptom that you said abnormal bleeding. Can you talk a little bit about what is actually abnormal? Because I think a lot of times we are trained to think what you're experiencing for your cycle is normal. So can you
Yeah.
talk a bit about what actually is abnormal bleeding?
Yeah, so abnormal uterine bleeding, we try to quantify it in the research realm and try to put a number on it with regards to doing studies. But really, ultimately, what is abnormal bleeding? None of us are going to be measuring exactly how much blood loss we're having with our cycle. So essentially, abnormal uterine bleeding is bleeding that is uncontrolled. So you are bleeding through your pad, your tampon, your clothes. You're needing to run to the restroom every hour, every couple hours in order to change because you're bleeding so heavily, or you're passing large clots. You're having lots of cramping, lots of cramping the past clots, or lots of cramping with your period. That would be considered abnormal uterine bleeding. Bleeding through onto the bed at night, having to get up in the middle of the night and change your pad or tampon because you're bleeding so heavily. That's abnormal bleeding. And any bleeding associated with symptoms of anemia, feeling lightheaded, feeling dizzy, feeling weak, bleeding that's so much that you can't go to work and you can't do your daily functions. That is, to me, more important clinically as far as categorizing abnormal bleeding than necessarily looking at, a specific number.
Yeah, we hear a lot from women when we're doing our patient education events that before they had treatment for their fibroids, they were taking a change of clothes to work all of the time. And they
Yeah.
was normal because they saw their mom take their clothes to work and change, or they would, their aunt,
Mhm.
when they went to a family function, would always change, and they would say, "Oh, she's so fancy. She's always having to clothes." But we
Mhm.
a lot that you think that what you're experiencing is normal because you've seen a lot of members in your family that have had the same symptoms or the same experiences that you're currently experiencing as someone with fibroids. Are you more
Mhm.
likely to have fibroids if someone in your family has been diagnosed with fibroids in the past?
Yeah, it's interesting you say that with regards to looking at your family members and their bleeding pattern. It's very true that if you have family members that have had fibroids, that you are at increased risk of having fibroids yourself. We definitely know there is a genetic predisposition to having fibroids.
And can you talk a little bit about the difference in race and ethnicity and more likely to have fibroids or not?
Yeah, we definitely know that it's not equal as far as the distribution of fibroids. We do tend to see it, especially African Americans, Latinos. We do tend to see these, specific patients that are at increased risk of it. So it's there's definitely an uneven kind of distribution with regards to ethnicity and the distribution of uterine fibroids.
And do you have any ideas or research that talks about what causes fibroids?
There are so many studies actually that are looking at what are the main causes of fibroids. And there is no real one isolated cause of fibroids. We know for sure there's a genetic predisposition. We know for sure we see it run in specific ethnicities. And we also know that we're diagnosing more of these. And is it that just our imaging modality is better, or is it that there is actually an increased prevalence of uterine fibroids and over time? And I think that there is an increased prevalence of uterine fibroids that we're seeing over time. And I think part of it has to do with our diet and potentially a lot of the hormones and things that are added into the diet. There's definitely some good data coming out that shows that there is an environmental impact on the prevalence of uterine fibroids. So we don't have any really great strong data to say, there's one specific fibroid gene, and if you have a gene, you're more predisposed. But there's a lot more data that's coming out that are looking at these risk factors and kind of putting these things together, which is great because then we can have more targeted therapy too, to try to mitigate some of these risk factors for patients.
So if women are having these symptoms, they know that they have the risk factors that you've mentioned. How do they find out if they've had fibroids? How do you actually get diagnosed with fibroids?
Sometimes you can diagnose it just based off of a pelvic exam, but the mainstay for diagnosing uterine fibroids is going to be a pelvic ultrasound or some type of pelvic imaging. Ultrasound is typically the first step with regards to being diagnosed with uterine fibroids.
Okay, that's great. And is that, just for the audience a little bit more of, is that the ultrasound that you get on your stomach, or is that an internal ultrasound that you would need to get?
Well, while the pelvic ultrasound, the one that you get on your stomach, is able to pick up a lot. Definitely the best way to really visualize the pelvic organs really is with the transvaginal approach, and that's the internal wand that's placed vaginally, similar to an early pregnancy ultrasound.
Okay, great. And can you talk a little bit about how many fibroids can you have or see when you're being diagnosed? Is it you have one fibroid? Are you seeing women that have multiple fibroids? Is there a pattern to, the number of fibroids that women are having?
Oh yeah, and that is totally across the page. I see some fibroid, or some patients, I should say, with one very large fibroid, and they're pretty dramatically impacted. I see patients with 60 or more fibroids, and they can range in size. So I would say that's completely across the page with regards to the number of fibroids and the size of fibroids and the impact on symptoms as well.
We hear a little bit about, and I think it would be beneficial for the audience to know of, the different size range of fibroids. A lot of times, as a physician, you'll explain kind of in a size of like a fruit range, or just what are the sizes of fibroids that a woman could have?
Yeah. Well, as far as symptomatic fibroids, part of it depends on size, but the other part of it depends on locations. I want to touch on that real quick too. There are, breaking it down to very easy terms, there's three areas where you could have a fibroid. There's inside the cavity. Those are called submucosal fibroids. Those are the fibroids that tend to have a big impact on bleeding, and they can be very symptomatic while still being very small. You can have a fibroid that's a centimeter and causing really heavy bleeding. And then we have intramural. Those are the fibroids that are inside the muscle wall of the uterus, and those fibroids can also have an impact on bleeding. They can cause pain. They can potentially have an impact on fertility as well, and they can range anywhere from centimeter or even less than a centimeter all the way up to multiple centimeters, sometimes even to the size of the uterus itself, or even larger than the uterus itself. And then you have the fibroids that are on the outside of the uterus. These are called subserosal fibroids. These are the fibroids that we typically think of that tend to grow quite large. And the reason being is because they have all this room in the abdomen to grow versus the ones that are in the muscle or the ones that are inside the cavity. And so subserosal fibroids tend not to be symptomatic until they are of a substantial size. So where I typically tend to see these fibroids start to cause symptoms, anywhere between the size of a golf ball and then onward from there. And sometimes we see these fibroids grow, really quite large, anywhere from that golf ball all the way up to the size of a watermelon. So.
Wow. So we have different symptoms, different sizes, different locations. Let's talk a little bit about what the different treatment options are. So we have a whole range of treatment options that you talk to your patients about, from kind of least invasive to most. Start at that lesser and least invasive range of what are those early treatment options that a woman could speak to her physician about once diagnosed with fibroids.
Yeah. And I think it's really important to highlight that fact that you just mentioned, that no one patient is going to have the same symptoms, the same presentation, the same amount of fibroid size of fibroids as another patient. And so it really is so important to be able to have and talk individualized treatment to that patient and talk to them about the pros and cons of all these different treatment options, because what's right for one patient might not be what's right for another patient. So with regards to the discussion regarding treatment options for fibroids, I typically will start the discussion with medication and diet and things that we can do there. With regards to diet, there's no one, tried and true, very specific fibroid diet. We do know that sometimes trying to avoid excess hormone in the diet through, dairy or animal product potentially may have an impact. But again, there's no real great data supporting that. There is more data coming out showing the impact of vitamin D3 and EGCG, which is a green tea extract, and adding this as a supplement is something I recommend across the board to my patients with uterine fibroids. Again, some data, but not a whole great big body of supporting data for that. With regards to medication, a lot of times we try to treat the symptom of fibroids, the heavy uterine bleeding, the pelvic pain. A lot of times, number one is still the birth control option. And now birth control is not necessarily a treatment for fibroids per se. Perhaps, yes, it may help with the bleeding, it may help with the pain, it may even help potentially slow down the growth of the fibroid, but it's not going to stop the growth. It's not going to stop fibroids from occurring. And so it's something to keep in mind that, if we get symptoms under control, knowing a patient who has fibroids, I would still monitor and continue to follow those fibroids, especially if they are planning fertility or if they have quite a few number of years before menopause. And then we have some other treatment options that are available now that are more targeted to specifically treatment of fibroids. So there are some medications out there, GRNH antagonists, for example, that they decrease the amount of estrogen and progesterone in our body to try to decrease the activity of the fibroids. Fibroids, we know, are very hormonally driven. They are driven by estrogen and progesterone. And as a sidebar to that, I have a lot of patients that ask me, they say, well, Dr. Stockwell, I have fibroids. Does that mean that my hormones are, overproducing? Does it mean my hormones are off? And that is not the case. Fibroids grow from a normal production of female hormones. So it's not that the estrogens are way off or the progesterone's way off. It's actually you're producing normal hormone, and that is what's triggering the fibroid to grow. So the GRNH antagonist medication, what it does is it decreases estrogen and progesterone in the body to help to deactivate that fibroid and prevent it from growing and potentially even see a little bit of shrinkage over time. The downside to the medication is there is a time limit that you can be on this medication because we bring your estrogen levels quite low, not quite menopausal low, but close to menopausal low. We don't want to keep you on this medication for more than 2 years max because we worry about increasing potentially someone's risk of osteoporosis. So there is that caveat to the medication. And then along with that, some mild menopausal type side effects as well. Hot flashes and night sweats are more common with the GRNH antagonists than they are with being on something like a birth control.
And I'm glad you brought up the fact that birth control helps with the symptoms, but not necessarily the fibroids, because a common theme that we hear from a lot of patients at our patient education events is they thought that they went on to the medication, and since their symptoms lessened, they thought that their fibroids had stopped growing. And so then they didn't go back to get looked at or checked, and then their fibroids had grown so large that they had medically managed themselves out essentially of some treatment options prior to having a hysterectomy. So can you talk a little bit about what are those mid-range treatment options that are available out there?
Yeah, so when medication is not an option or medication has failed or patient wants to be a little bit more proactive with regards to treatment of the fibroids, we do have quite a few procedural options that are available now. One of them being radiofrequency ablation, which of course Sonata has a huge part in that. Radiofrequency ablation essentially is heating the fibroid up from the inside out. We heat the fibroid up to a high degree temperature that it denatures the proteins in that fibroid. So the fibroid goes from this hard material to more of a soft material. So from the baseball to more marshmallow type of material, and your body will start to absorb that fibroid over time. We also tend to see a lot of shrinkage with the fibroid volume over time as well. But with regards to those bulk symptoms, pushing on the bladder, pushing on the bowel, those symptoms tend to improve. And we also see, of course, the number one symptom, the abnormal uterine bleeding because of fibroids. We see improvement in that as well. So that's one of the procedural options that are available, and that is not contraindicated in someone who wants future pregnancy. So it's definitely still an option that's available for someone who doesn't want a more invasive procedure, but maybe has tried medication or medication is not a good option for them to preserve the uterus and also preserve their fertility. With regards to fertility and a patient who may want a minimally invasive approach, but doesn't necessarily need to preserve fertility, there's also the uterine artery embolization. This is a procedure that's done in interventional radiology where they go through a vessel in the groin and they feed a guide wire up to the vessels that feed the fibroid. And on fluoroscopy, on x-ray, they're able to block those vessels that feed the fibroid and essentially cut off the blood supply to the fibroid. So the fibroid starts to necrose, it starts to die, and it starts to shrink. Not recommended for patients who do desire future fertility, though, because we worry about the theoretical risk of disrupting the blood supply to that area of the uterus and supporting a future pregnancy. So there is that caveat on that. And there's also a size limit on the fibroids that you can treat with that. It's not recommended for anybody with fibroids that are 10 centimeters or greater because of the efficacy, but also the amount of necrosis that you get. The necrosis process after uterine artery embolization can be painful. So while it's a minimally invasive approach to surgery, sometimes patients can have a good amount of pain in the recovery process after that procedure. So something to keep in mind.
And how long is the recovery for that on average?
Well, the recovery with regards to lifting restrictions and those it's very quick. It's a same-day procedure and taking it easy for a week or two. But with regards to the actual necrosis of the fibroids, that can be, even a several month process before we see reduction in the fibroids and reduction in the inflammation after that procedure. And I'm just going to compare real quick compared to the radiofrequency ablation. The type of necrosis that happens with radiofrequency ablation is a different type of necrosis, the heat versus the cutting off the blood supply. The coagulated necrosis that happens with applying heat to the fibroid tends to be a less painful type of shrinkage, a less painful type of necrosis. So, but both of those recoveries are definitely quicker than a myomectomy or a hysterectomy procedure.
And can you explain briefly what a myomectomy is?
Myomectomy essentially just means removal of fibroid. So there's different ways of doing myomectomy. Remember I mentioned there's fibroids that can grow inside the cavity. You can have fibroids that grow within the muscle wall of the uterus, or you can have fibroids that grow on the outside of the uterus, and they're approached differently. So for example, if you have a fibroid that's inside the cavity, you can do what's called a hysteroscopic myomectomy. And that's a procedure where there's no incisions on the abdomen. You go through the cervix with a camera. You're able to directly visualize that fibroid, and you're able to shave down that fibroid and remove that fibroid. If that is the only fibroid that needs to be approached inside the cavity and no intramural or inside the wall, outside of the wall type of fibroids, then that recovery is very quick. Because there's no incisions, there's no lifting restrictions afterwards. It's just pelvic rest, essentially no sex, no tampons, nothing vaginally for the first week or two after surgery. If you have fibroid, multiple locations, so if you have a intracavitary, but you also have it in the wall, you have it on the outside, or if we're just talking about fibroids inside the wall or fibroids that are on the outside of the uterus, with regards to myomectomy, that would have to be approached from above. You're not able to access those from going specifically just inside the cavity. And so that would be either done laparoscopically or robotically, which is done through tiny incisions, or what we call keyhole incisions, usually a handful of incisions, up to 4 or 5 incisions across the belly for that, that are each tinier than a centimeter. Versus an abdominal myomectomy, if you have very large and numerous fibroids, which is done through a big incision, either an up and down incision or the bikini cut or classic kind of C-section type of incision, depending on location and size of fibroids.
And then what we hear women are offered a lot as their only treatment option is a hysterectomy. So a few things that I would love for you to talk about. One, what is a hysterectomy? And then also a partial hysterectomy versus full. And the misconception that you go into menopause whenever you have a hysterectomy.
Yeah, I'm happy to answer that. I think, before we had all these different treatment options that are available, women they were offered in birth control, and when that didn't work, they were recommended to undergo hysterectomy quite often. It still is fibroids are still the number one reason why we do hysterectomies. But the number of hysterectomies we've seen over the last several years, have actually declined because we have all these other minimally invasive approaches to try to preserve the uterus and to provide relief without necessarily needing to undergo a big major surgery like a hysterectomy. The hysterectomy essentially is removal of the uterus, and I hear this all the time from patients. They're very worried about hysterectomy because they are worried about, as we said, going into menopause. A partial hysterectomy is removal of just the uterus. So the uterus, typically either with or without the cervix. Typically when we're talking about treatment of fibroids, we do recommend removal of the cervix so that you don't go on to grow fibroids from that cervix that's left behind. And that's essentially a hysterectomy. When we add on the ovaries, the medical jargon for that is called oophorectomy, and that would be what pushes it to a complete hysterectomy or a full hysterectomy. But that is not needed. Your ovaries are not needed to be removed in order to treat the fibroids. Your ovaries have a lot of benefit of even past menopause for bone health, heart health, overall longevity, prevention of dementia. I mean, there's very little reason why a woman undergoing a hysterectomy for fibroids would actually need to have her ovaries out. In fact, I counsel patients, unless they have risk factors for ovarian cancer, if they have a strong family history or a genetic predisposition, certain genes that increase their risk of ovarian cancer, I have very little reason to actually remove ovaries that look normal and seem to be functioning normal in order to treat the fibroids. So after hysterectomy, would not have periods, so it would be definitive treatment for the fibroids. We shouldn't have to worry about fibroids ever coming back again, and shouldn't have to go on hormone replacement therapy because you still have your normal hormonal function from your ovaries.
That's all good information. And I think it's so important for women to understand what that range of treatment options is that is available to them, and how important it is for them to find a physician like you who is talking to them about all of their treatment options. Because, like you said, every woman, fibroid, location, size is different. And that really is going to determine what your best treatment plan is going to be for those fibroids.
Yeah.
I would like to talk a little bit about, more specifically of what is Sonata and what is the Sonata treatment. So if you could just give kind of a brief overview of how you explain Sonata to your patients.
Yeah.
I think start.
Yeah, no, I'm happy to. So Sonata is a transcervical approach for radiofrequency ablation. So essentially what that means is there are no incisions. We are able to insert a probe that is not much, not much thicker than my pen here. Able to insert a probe through the cervix that has an ultrasound on it. So everything is done under visualization with using an ultrasound, and it has a tiny needle array that comes out and is deployed into the fibroid, and I'm able to monitor the temperature the entire time. I'm able to watch on the ultrasound imaging the entire time, and I'm able to specifically apply the energy, the heat, directly targeted to the fibroid itself. So I'm able to really isolate my therapy, my treatment specifically to that fibroid, and make sure I'm not going to hit anything else, such as the healthy muscle tissue that's right next to that fibroid inside the uterus that I want to preserve, especially in a patient who really wants to preserve fertility. And so it's a very safe procedure that can have pretty dramatic improvement in symptoms and pretty dramatic benefits for patient, with a very quick recovery, no need for lifting restrictions, pretty minimal pain relief, and pretty minimal risk factors with regards to the procedure.
And can you talk a little bit about when a woman is a candidate for Sonata, what does that procedure day look like? Are they going under anesthesia? Are they staying overnight in the hospital? What is your typical experience with the patients when you're treating with Sonata?
Yeah, well, let's start with the correct candidate for Sonata. So as we mentioned before, not one treatment is necessarily going to cover for every single patient with uterine fibroids, and that's for all of the treatment options. So with regards to Sonata, it's best targeted for patients who have really a range of different fibroid sizes and locations of fibroids. That can treat submucosal fibroids inside the cavity. It can treat inside the muscle wall, and even a little bit extending to the outer surface of the uterus as well. The fibroids that it's not necessarily the best treatment for are those that are way outside the uterus. We call fibroids that are on a stalk. So if, for example, if they have a little stalk and they're kind of growing off of the uterus, those fibroids are not necessarily the best treatment option for radiofrequency ablation. And the reason being is those fibroids they could come off and they could start to grow elsewhere or necrose and cause issues. Same thing inside the cavity. If there's any fibroid that is on a little stalk, that might not be the best fibroid to treat with the radiofrequency ablation. Those aside, really the majority of fibers are really able to be approached and treated with the radiofrequency ablation. And so, first of all, it's talking to patients about who is a good candidate. And then as far as the procedure day, what that looks like. In my practice, I do these under sedation in the operating room. However, there are some providers who will do it in the office as well, also under some sedation. So for my patients, it's a same-day procedure. The length of procedure depends on how many fibroids that we're treating. I have some patients where I'm treating 1 or 2 fibroids, and those are very, very quick procedures. It takes maybe 5 minutes per fibroid to treat it max, and then very little time under anesthesia. I also have other patients who have a number of fibroids, and that takes a little bit more time because each fibroid that you're treating does take some time, and you're continuously monitoring this with the ultrasound and making sure that you are treating every fibroid to give that patient the maximal benefit. So for those patients, it may take a little bit longer, but no overnight stay. In fact, when I first started doing those procedures, I would provide my patients with pain medication for after surgery, and the majority of my patients have told me I didn't need to take any pain medication, maybe some over-the-counter pain medication. In my practice, actually have completely stopped prescribing any type of pain medication after this procedure, just because I've had so many patients that did so well and didn't need anything stronger than over-the-counter pain medication. As far as return to normal function, taking, of course, that day of the procedure off and the next day off. The grand majority of my patients are really able to get back to normal function, get back to work within really just days after the procedure.
We hear that a lot from our patients, and I think that, you hear a lot that women tend to wait because they don't have time to recover and take care of themselves because they're so busy taking care of everyone else and doing everything else. So it's really exciting that we're able to offer women a treatment option that does allow them to get back to normal activity quickly, but in addition, treat their fibroids in a way that allows them to do that. Are there side effects, or when they go home, do you have patients that are experiencing anything after having Sonata, or just any other things that women should know or expect, or that they don't have that they should know?
Yeah, I mean, I think just like any procedure, nothing is ever 100%. And so while we have really high success rates and patients tend to do really well, it's continuing to monitor symptoms and monitor for the improvement. It's important, I think, to keep in mind that with the radiofrequency ablation, you have to give it some time as well. You have to give it some time to see that improvement over time. And we're not removing the fibroid, we're altering the fibroid, we're inactivating that fibroid, and we are going to see improvement in that fibroid over time. But if you got an ultrasound the next day, we're not going to see dramatic shrinkage or anything with the fibroid. So I think it's important, and I always talk to my patients about following their symptoms really for a good 3 months, 3 cycles or so, even up to 6 months after the procedure, to watch for that improvement over time. Now, most of my patients have noticed, very quickly within the first cycle or 2 after surgery, that they notice pretty dramatic improvement. But if a patient, that first cycle afterwards is still having a heavier cycle, I reassure them and say, okay, well, let's track this, let's mark this, let's see the improvement over time. And I think it's important, really, for any patients with fibroids, is I strongly recommend doing period tracking so that you can go back and see have my cycles change over time? Have they become heavier? Have they become more painful? Has the frequency changed? Are they getting shorter or longer? And that is a good way of tracking to see, your fibroids, for how much it's impacting your cycles, impacting your quality of life, and maybe looking back and saying, okay, well, maybe now is the time to go talk to a doctor or a provider and seek some treatment for the fibroids.
A question that we hear a lot is, can fibroids come back? So once you treat a fibroid, can that fibroid come back?
So the short answer to that is yes. So fibroids, for example, fibroids that maybe are not fully or adequately treated, could potentially continue to grow. Fibroids that are, slow growing for a period of time sometimes can start to then grow faster. Myomectomy, removal of a fibroid, that individual fibroid shouldn't necessarily grow back unless you've left part of it there, but you could develop new fibroids, and you could develop new fibroids even in that same area. Patients who are already predisposed or increased risk to grow fibroids, definitely can have fibroids that grow, further fibroids that grow, or like you said, fibroids that grow back again or start to grow after a period of time again.
And my last question, if there are any questions out there, feel free to put them in, and we'll have Dr. Stockwell answer those. What kind of feedback do you receive from women who have received Sonata, as far as, how their life has changed from before they had Sonata to after having the treatment?
Oh yeah, I've been very happy with the outcome that I've seen with my patients. As you mentioned, I come from a biomedical engineering background, so I think I'm very oftentimes kind of skeptical with new devices and new technology that comes out. I really want to get into the meat of it and make sure that it makes sense and make sure that it works and works well for my patients, and so I'm also very much interested in innovation and seeing what comes out, and always kind of pushing the envelope to see what are going to be the best treatment options for my patients. And I have definitely become a believer in Sonata, just through patient experience and being able to see firsthand how it's impacted quality of life. I've followed patients initially because I was a skeptic and I wanted to really track and see their symptoms. I wanted to monitor the fibroids on imaging. I wanted to see that the change over time, and I have, and patients have sent their friends and their family and their coworkers now to ask about the procedure. So I definitely have become a believer over time, and but just with how well patients have done.
That's great. That's really great. We are very thankful to have you here on our first episode. You've had a wealth of information that you've shared. So thank you for that. And thank you very much for being a treating physician of Sonata and being a physician who speaks to women about all of their treatment options that they have available, including Sonata, to empower them with the information that they need to know to take control of their health. So thank you very much. We will be putting up at the end of this webinar a screen that has our website, which is sonatatreatment.com, where you can go and find our physician finder, where you can find Dr. Stockwell in Florida to schedule a consultation, as well as other physicians that we have across the country that are in your area. If you would like to schedule a consultation to learn more about Sonata. Thank you very much, Dr. Stockwell. We appreciate you being here, and hopefully everyone will join us for our next episode on September 3rd. We will be putting up our safety and indication information for you to take a look, which will be followed by the website information where you can schedule a consultation with Dr. Stockwell, talk to one of our nurse advocates at Gynesonics, and look for physicians across the country for a consultation. Thank you.